था कि ना आप डॉक्टर पंकज अब्रोल और सबका नाम लिया कि इनके साथ मिलकर मनोज शुरू करो तुम अपना ये पीजी टीचिंग एक्टिविटी। कहता कि स्टेट कॉन्फ्रेंस होती है और उसके अंदर पीजीज का कोई रोल ना हो, उसका कोई वो नहीं है यार, मजा नहीं है बिल्कुल भी।
नहीं, हम जो हरियाणा स्टेट
अब ये शुरू किया
इस बार हम हरियाणा स्टेट कॉन्फ्रेंस में पेपर प्रेजेंटेशन और पोस्टर प्रेजेंटेशन करेंगे।
बिल्कुल, पेपर प्रेजेंटेशन रखना और अवार्ड रखेंगे बड़े वाला भाई उसके अंदर। अमाउंट मैं डिसाइड करूँ,
हमारे सारे पीजी आएंगे सर, फिर
अमाउंट मेरी तरफ से रहेगा वो वाला।
चलो, थैंक यू
नवीन।
ठीक है, सीमा
मैं पेपर और पोस्टर प्रेजेंटेशन दोनों होंगे, दोनों में अवार्ड भी रखेंगे जरूर, फर्स्ट सेकंड थर्ड जनाब।
लेट अस स्टार्ट।
यस सर।
हाँ स्टार्ट कर सकते हैं यार, कोई नहीं, बाकी लोग ज्वाइन करेंगे धीरे धीरे।
यस सर।
डॉक्टर रोमित जैन, वेलकम। डॉक्टर रोमित।
थैंक यू सर, गुड इवनिंग सर।
मेरे को सुरेंद्र ने इतनी प्रेज किया आपकी, मैंने गूगल पे सर्च किया, मैंने रिव्यू नहीं दिया, खैर हमारे डॉक्टर साहब हैं, पर आई एम हाईली इम्प्रेस्ड अकेडमी के लिए। थैंक यू।
थैंक्स।
I think it is time we should start. Dear friends, I welcome you all for today's academic program. It was a long cherished dream to start a postgraduate teaching activity in Haryana. We have a lot of MD, diploma and DNB students in Haryana. We are proud to have 12 medical colleges in Haryana now, with 4 of them having postgraduate courses. And soon many others will join. This year, due to COVID, there was some restrictions. Otherwise, many would have gone for post-graduation this year also. So hopefully by the end of this July, we will have 2 or 3 more colleges having post-graduation. Besides Gurgaon and Faridabad and Rohtak having post-graduate courses in the form of DNB at many hospitals. Respected faculty members, teachers, thank you for creating this postgraduate teaching activity and joining this teachers group. Special thanks to Dr. Manoj Rawal, who is the academic coordinator and is the basic idea and brain behind this all activity, who has promised me to continue this in his tenure next year since he is the president-elect. Today we are starting with the first activity, and our very dynamic, brilliant Dr. Surendra Gudhara from Maulana Maharaja Agrasen Medical College, Agroha, has consented to start with the first case and the most difficult one, a case of neurology. So I welcome Dr. Surendra to kindly take over and introduce our case, our presenter and our chairperson, Dr. Romit Jain, for today. Thank you.
Thank you, sir. So we have planned a case-based discussion on neurology case, which will be presented by Dr. Amit, third year DNB postgraduate at Maharaja Agrasen Medical College. I welcome our guest faculty for today's case, Dr. Romit Jain, consultant pediatric neurologist at Open Neuro Hospital, Amritsar, and he is trained in one of the pioneer institute of pediatric neurology, Rainbow Children Hospital, Hyderabad. I welcome all the PG students joined here and all the esteemed IAP faculty members. Haryana. Initiation of this PG active was the long cherished dream of our president, our Dr. Naveen Gupta sir, and President-elect Dr. Manoj Rawal sir. And today we are going to start the first PG activity. Now I would like to invite Dr. Amit for case presentation. Please share your screen and start. Thank you.
Good evening, sir, ma'am, and everyone from faculty and my colleagues. Today's case will be of a patient 8-year-old. Case will be of CNS.
Please share your screen first.
Good evening, everyone. We will start with the case. I am presenting today the case of Anjali, 8-month-old female, born of non-consanguineous marriage, Hindu by religion, and resident of Hisar. She was brought by her mother, and informant is her mother herself, which seems fairly reliable. The chief complaints are delayed achievement of milestones since birth and paroxysmal abnormal jerky movements of all 4 limbs since last 15 days. As the early neonatal history is significant, I would like to start my history from antenatal and birth history. It was a spontaneous conception at 22 years of age of mother. She was registered with pregnancy at 3 months of gestation. She received iron folic acid tablet for around 2 months, and 2 TT injections were given. There was no history of fever with rash or painful swelling behind ears or radiation exposure in any of the trimesters. There was no history of elevated BP or long-term drug intake. There was no significant history of decreased fetal movements perceived by mother during the pregnancy. In the birth history, the delivery was term cesarean section delivered due to meconium strain liquor. Birth weight was 2.5 kg, and there was no admission at the time of birth. Exclusive breastfeeding was started on day 2 of life. Patient was admitted in NICU on day 3 of life with complaint of abnormal body movements with increased tone of all 4 limbs, with uprolling of eyeballs, which lasted for 1 to 2 minutes, and there was no loss of consciousness after that. Patient was admitted in NICU for 9 days, and as per mother, low sugar levels were detected at that time of admission. After 9 days of admission, patient was discharged, and no long-term AED anti-epileptic drugs were prescribed at the time of discharge. There was no history of jaundice, constipation, excessive cry, or lethargy, or any other history suggestive of neonatal sepsis. After the birth history, I will like to continue with the developmental history, which is the chief complaint itself. The mother complained that the child started holding her head at age of 6 months, and now she only maintains a chest off the couch. The DQ at that time was at 6 months was 50%. It still remains the 50%. And highest achieved milestone is the chest of the couch in prone position. In fine motor milestone, the bidextrous reach was achieved at 5 months of age. DQ was at 80%. Unidextrous approach was reached at 7 months, last month, that is. DQ is almost 78%. In the language milestones, the patient is able to speak monosyllables, the DQ being 75%, no bisyllables achieved at present. In social milestone, social smile was achieved at around 2.5 months of age. DQ was 83%. She started recognizing her mother at 4 months of age. DQ was 75%. Stranger agent is present at this point of time at 7 months of age, and DQ is almost 85%. Development history chiefly suggests a significant gross motor delay and no significant delay in other domains. Now, after the development history, now patient developed abnormal movements since last 15 days in the form of sudden jerky movements of all 4 limbs with flexion of head lasting for 1 to 2 seconds and single jerk at a time. According to the mother, abnormal body movements were more after waking up in the morning, and 10 to 15 episodes per day were there with clustering of movements in early morning. There is no associated uprolling of eyeballs, loss of consciousness, frothing from mouth, or spontaneous loss of bowel or bladder control. There is no history of fever, loose stool, vomiting. There is no history of trauma or cyanosis before or at the time of episode. There is no history of behavioral abnormality in the form of excessive cry. There is no history of deviation of eyes, drooling of saliva, abnormal nodding of head, decreased alertness to the sound, or nystagmus. there is no history suggestive of positive of movement. There is no history suggestive of focal neurological deficits. There is no history of difficulty in changing diapers due to raised tone probably, or no history of slipping through hands of the mother. After this history, then in the past history, there was no further episode or other significant past history apart from the admission at the day 3 days of life. I'm sorry, it is wrongly written. 3 days of life. Family history is no significant. It's the firstborn child, and no other sibling is as per no such complaints were there in father or mother. In the dietary history,
we'll stop here, Amit.
Yes, sir.
Yeah. We'll go to the first slide.
Yes, sir.
Okay. So, can you tell me what's the summary of your chief complaint? What's your thought process here when you see these 2 chief complaints?
Sir, probably some insult in the early neonatal period leading to a remote kind of epilepsy and delayed achievement of significant gross motor milestone, probably due to injury in perinatal or early neonatal period,
Okay.
involving mostly cortex.
So we are looking some at injury at some early developmental phase of the child. Okay, right. Go
Yes,
to
sir.
the next slide.
Sir.
Okay. Can you tell me, go to the developmental history?
Yes, sir.
Yeah. So can you give me the crux, the summary of developmental history? What is your inference of this developmental history?
Sir, gross motor milestone are chiefly delayed, which is also seems to be static, and the disease is not progressive. Second thing is other milestone or other domains remains unaffected.
So how can you say that the milestones are unaffected? There is a delay, maybe not as much as gross motor, but there is a delay. So what type of history did you take in gross motor? Can you tell me all the history? What is expected at this age? Say 8-month-old girl child. So what should be asked?
Sir, in gross motor, sir, at 8 months, sir, at 6 months itself, patient should be able to sit in a tripod fashion with without a support.
Right.
Sir, at around 8 months, patient should be same sitting without support, and in around 9 months of age, standing without support should the patient should be able to achieve.
What I mean to say is, can you tell me the differentials where the motor milestones will be affected more in comparison to other domains? That is the basis of our taking the different domains of history, right? So
Sir.
What is your thought process when you see a gross motor being affected more than your fine motor and speech and language and social milestones?
Sir, maybe some localized insult to the localized insult sir, to the cortex involving mainly parasagittal area, affecting the limbs more and gross motor more, sparing the other parts of cortex like language and other parts.
See, it's not an isolated motor delay. Even from your history, it is obvious it is a global developmental delay. It is not only gross motor developmental delay. So it's a diffuse injury. It's not a localized injury. Even from history, we can say that. But there seems to be some confusion in the development history. I don't think so. There would be so much of difference in the gross motor and fine motor milestones and your social milestones as such. Okay. But anyways, for our sake, can you tell us if a child has isolated motor developmental delay and is normal, other domains are normal, so the cognitive milestones are normal, what will be your thought process? So how does this developmental history help us in reaching a probable etiological diagnosis?
Sir, probably some peripheral involvement of muscular system, musculoskeletal system, muscular dystrophy.
So it's a neuromuscular disease. We are looking towards a neuromuscular disease if it's a isolated motor involvement, right? So if motor involvement is more than the other milestones, it's a global developmental delay, but motor is more involved than cognitive milestones.
Yes.
So what is the differential then? Well, there can be a lot of differentials, but the common ones.
Yes, sir. Sir, static encephalopathy, including cerebral palsy.
No, that is a very broad term. So supposingly a child who is not able to say achieve motor milestones, the motor milestones are delayed. Say he starts sitting at around 1 year and starts walking by 2 years of age, but he is speaking bisyllables, he's recognizing, he has some social mimicry. What is going to be your thought process? Which type of static encephalopathy will present with predominant motor more than cognitive delay is what I'm asking. It's a very common, like periventricular leukomalacia, right?
Yes, sir. Preterm injury to the preterm
type of spasticity, where children will have predominantly motor delay. They will not be able to walk as early as they should, but the cognitive wise adaptive milestones, they are relatively preserved in such children, right?
Yes.
So if motor and social milestones are equally affected, which type of static encephalopathy are we looking at? Am I clear? Is the question clear?
Yes, sir. Yes, sir. So then, the global developmental delay will be there, and sir, causes maybe hypothyroidism.
In terms of static encephalopathy, like you were telling about static encephalopathy, I want to differentiate based on the developmental milestones alone. So it is going to be a quadriplegic type of severe global developmental delay, right?
Yes.
So you are looking at a diffuse multicystic leukoencephalomalacia or other type of patterns there. Okay. So if there's a child in developmental history, you find the motor milestones are normal and only social cognitive milestones are delayed. What is going to be the thought process? So if there's a child who comes to at say 3 years of age, it's a very common scenario. He's walking, running, but he's not. He has not achieved the social milestones.
Sir, autism spectrum,
pervasive developmental disorders, autism, right? Excellent.
Yes, sir.
So based on the history, developmental history, whether it's a global developmental delay or one of the domains is predominantly affected, we can arrive at a probable etiological diagnosis, or at least what are the areas we are expecting, because we are going to take the history similarly. So, okay, right. So, yeah, next slide. Okay, you told me that it's a static encephalopathy. Can you explain me why you said that based on your history?
So developmental, DQ is basically not deteriorating, and patient has not experienced regression of milestone.
Okay, right. So that is the basic concept behind it, but it is too early to say whether it is a static encephalopathy or a neurodegenerative process. The general conception is that usually with a neurodegenerative disease, the child must have lost some milestones by now, but it is not always the case, right? The plateauing of the milestones, this could be the child where the milestones will be plateaued. Okay, so at a single point of examination, it is very difficult to say. You need to follow up these children and then you need to reach the diagnosis whether it's a static encephalopathy or a neurodegenerative disease. But given the history of significant perinatal insult, yes, you are right, it is likely to be a static encephalopathy. Okay, okay, right. So next slide. Okay. Because have we completed the history part, right? History of present illness and everything.
Yes, sir.
Okay. So I expect you to include all the things in your history. So including comorbidities. So when you are asking there's a case of global developmental delay that we are discussing right now. So in the history, you are going to ask the parents of all the possible comorbidities the child can have. One of the comorbidities you have described is seizures.
Yes,
okay. And we'll come to that topic also of seizures that you have described. But what are the other comorbidities that you should have asked in the history? In the case of global developmental delay, what are the other issues that the child can have that you should have asked?
Sir, comorbidity related to increased tone and dystonia.
Okay, so how will you ask the history of dystonia?
Sir, abnormal sustained posturing. difficulty in changing diapers, maybe.
So
And,
difficulty in changing diaper is spasticity, basically twisting, like you said, a particularly maintained twisting type of posture.
Maintained twist.
Does the child
Yes,
does
yes,
that? Okay,
yes,
so dystonia, yes, one of the component is dystonia. Other comorbidities. There are a lot of comorbidities. Like somebody has also, I think, mentioned in the
bowel and bladder involvement, sir.
Okay, so what you are going to ask in bladder and bowel involvement at 8 months of age?
It is not significant.
So
At 8
a
months.
child that comes to you at 8 months of age, he might be having a lot of issues other than just having seizure. Seizure is just one part of a big problem, right? So he might be having severe constipation. There may be swallowing difficulty. There must be drooling of saliva. There might be squint. The child may not be able to see. The child may not be able to hear. So this all history you have to include among the present illness.
Yes,
That is why once you take the history, the same things you have to confirm in your examination findings. So unless you ask these things in the present history, it's going to be difficult. So, so whether this child has constipation, have you asked for these things?
sir. Sir, I'll ask for constipation. No issue. There is no issue of constipation.
There is no history of constipation. Okay, right. And you told that the child recognizes the mother,
Sir.
right? So it's very important because from whatever history you are giving, we are heading towards a particular entity. Can you tell me, does the child recognize mother by her voice or after seeing her face, and why is it important?
Sir, the child recognizes by seeing her mother only, because
Okay. Okay.
and sir, importance is probably due to sir, insult may lead to sir cortical blindness. Then patient may just alert to the sound only and not to the vision.
Excellent, excellent. So specifically when you mentioned there is a hypoglycemia, I wanted to make
Yes,
this
sir.
special point because we know the predisposing areas of hypoglycemia, and usually these children will have cortical vision impairment. So the usual history that we get in such cases is that the child recognizes their guardians or their attendants through voice and not only by seeing the face of the mother most of the times. So maximum times the confusion is because the mother is approaching the child, she is going to call out the name also. So sometimes the parents feel that the child is recognizing the face also, the visual cues also, but that is not the case in most of these injuries, right? Okay. So yeah, go to the birth history. Sorry, the neonatal admission. Yeah. Can you tell me what is happening here? What is your thought process? Or what is the localization? How are you going to take it forward?
Sir, at day 3 of life, patient was admitted with a single episode of abnormal body movement of increased tone also. Sir, as per history is very clear in this case because the mother herself told about this low sugar levels at the time detected.
So we are looking at a neonatal hypoglycemic brain injury most likely here. So in most of the scenarios, in most of the cases, this history is not given by the parents. It is not even conveyed to the parents that the child has hypoglycemia while staying in the NICU. So what are the cues? Because it's a very common complication that comes up during history taking. The parents will say the child did not cry at birth. Okay. And can you tell me, when is crying at birth, not crying at birth, significant enough? So what history you are going to ask the parents to ascertain whether not crying at birth was a significant sentinel event or not?
Sir, probably if more than 1 minute of bag and mask application was used at the time of resuscitation, then it becomes significant for neonatal admission and further complications.
I'm not asking the treatment guidelines. So I'm telling you a scenario where when we are going to take history from the parents कि बच्चा जन्म के टाइम पे रोया था कि नहीं रोया था, most of the parents by default we say शायद नहीं रोया था सर, हमको अभी तक यही बताया गया है कि बच्चा नहीं रोया इसीलिए आपका बच्चा delayed है. But most of the times what we have seen is the history is not significant. It is not a case of perinatal asphyxia. There are other factors that lead to global developmental delay. So कैसे पता लगेगा? What I'm trying to say is कि neonatal hypoxic ischemic encephalopathy था क्या नहीं था बच्चे को at birth.
Sir, whether there was history of admission or oxygen support,
Yeah, right.
or sir, feeding difficulties, letharginess in the early
Right.
neonatal period.
So basically, you have to ask the history of encephalopathy.
Encephalopathy.
The not crying at birth is not a diagnostic criteria to say that the child had HI. Okay.
Yes,
So if the child was lethargic, child had seizures, child was on ventilator, there was significant lethargy and all those things, the child was not, we were not able to initiate the feeds, then it is a significant HI history. Otherwise, just not crying at birth doesn't qualify the child to be called as perinatal asphyxia. Okay. The day of seizure, how important is the day of seizure in your perinatal history? So a child, a neonate that had seizures on day 1 of life versus a child who had seizures at say day 3 of life versus a child who had seizures at day 5 of life. How does seizures help you in deciding what is the probable etiology?
Sir, hypoxic ischemic seizure mostly present within 24 to 48 hours. Sir.
Excellent, excellent. So within 24 hours of life, they have a typical crescendo decrescendo pattern. So day 1 seizures are usually exclusively hypoxic ischemic encephalopathy seizures, right?
Sir, then sir, if the baby is premature, maybe 48 to 72 hours, sir, in intraventricular bleed or may cause seizures.
Right.
And then sir, in later part, late neonatal sepsis, for example, sir, meningitis may cause seizures. And
right. So 3 or 4 important points while deciding the seizures is day 1 seizures are usually hypoxic ischemic encephalopathy. Day 3 seizures or day 2 to 3 or 4 seizures are usually hypoglycemic seizures. Okay. And day 5, 6 seizures are usually infective seizures, meningitis sort of things. So even the day of seizure will tell you. Okay. Right. Okay. Proceed. So yeah. So you can you tell me from your history, where is your localization? What are you your anatomical localization? What is the probable etiopathogenesis of your lesion? What has led to the global developmental delay in this child? So you are saying it's a static encephalopathy. It's a probable neonatal hypoglycemic brain injury.
Yes.
And the seizures that you have described are basically epileptic spasms, right?
Yes, sir. Epileptic.
Right. Okay. Please proceed further.
Sir, in the dietary history, patient is vegetarian and complementary feeding since 6 months of age, consuming 700 kilocalories, deficit of 200, and taking 7 gram of protein with a deficit of 4 gram. Sir, immunization history, it is complete as per national immunization schedule. BCG score was present. In the socioeconomic history, sir, they have a pakka house with good ventilation, but it's a rented house. Water supply is from municipality and adequate sewerage is there. So they belong to upper lower total score of 9 by modified Kupuswamy scale. Sir, in the summary, I would like to summarize as 8-year-old female with significant gross motor delay, along with other domains delay, with sudden spasmic movement of all 4 limbs, and along with head with 1 jerk at a time, more after waking up since last 15 days, with no loss of consciousness, no focal neurological deficit, with no precipitating factors, and significant insult to brain in early neonatal period suggestive of hypoglycemic, with no history suggestive of increased tone or other comorbidity.
Okay. Yeah, I think first thing is there is focal neurological deficits, right? The child has significant global developmental delay. ऐसा नहीं है कि focal deficits नहीं है. And second thing is you should be brief in your summary. So it is possible epileptic spasms only, no? What is sudden spasm movement of all 4 limbs with head and 1 jerk at a time? So it is epileptic spasm, and whenever you are taking history of epileptic spasm, you should ask for regression of milestones. Most of the cases, almost all the cases of epileptic spasm after starting spasms or even slightly before starting spasm will have regression, especially social regression. So most of the children will lose their social smile and recognition by that time. Okay. Does this child have any neuroregression after the spasms?
Sir, there is no. Sir, we have history of only 15 days, but since last 15 days there is no apparent regression of any social or psychomotor.
Oh,
domain.
okay. Right. So it's 8 months old girl, not years. 8 months old girl
Sorry,
with
sir, that was by
global delay with
yes, sir.
static encephalopathy, epileptic spasm starting
Spasm.
15 days back,
Yes.
and possible insult that we are looking at is a hypoglycemic insult, right?
Yes. Yes.
So what is the possible etiology here? What is the possible etiology? Can it be an inborn error of metabolism? Can it be a genetic condition?
Sir, for inborn error of metabolism, sir, the soul with the basis of history, we cannot.
Okay, but the possibility is there, isn't it?
But possibility is there.
Okay, what are the points favoring your diagnosis of a static encephalopathy? Means to say that it was a one-time insult of a hypoglycemia versus
Yes, sir.
that it can be some metabolic disorder. Can you differentiate based on the history?
Sir, there must have been recurrent seizure since since the admission. There must have been the history of recurrent seizure if there have been inborn error of metabolism or such kind of pathology.
Although
But patient was
always, yeah, but yes. So if it was a metabolic disorder, by now the child would have might have
yes,
regressed, or he
might
might have
been.
other sentinel events also by this time.
Yes.
So less likely, but still possible. We'll keep it
Yes,
at a distant possibility. Yeah,
Yes.
right.
Should I move?
We'll move. Yeah, yeah.
Now the examination part. In general physical examination, patient is alert, awake, and interested in surroundings and interacting with mother, playing in the bed. And her vitals are her heart rate is 98 per minute, pulse rate is also 98 per minute, regular with normal volume, no delay. It was taken in right radial, brachial, and dorsalis pedis. Respiratory rate is 28 per minute. Respiration was regular abdominothoracic. Patient is afebrile to touch, and 98.6 Fahrenheit was taken in right axilla. Sir, there is no pallor, icterus cyanosis, clubbing, or lymphadenopathy in the child. In the anthropometry, her weight is 7.4 kg, which, and according to WHO, weight for is lies in -1 to 1 mean. Length is 73 centimeter, and length for is lies in median to +1 standard deviation. Her head circumference is 41 centimeter, which lies at -1 standard deviation to mean, which signifies it's as normal. Mid upper circumference is 12.5 centimeter, which is normal, and upper segment is to lower segment ratio is 1.4:1, which also appears to be normal. In head to toe examination, sir, head shape is apparently normal except for slightly flat occiput. Eyes and mouth appears normal with no deviation or no squint or no signs of vitamin deficiency. There is no facial dysmorphism, dysmorphic features present. There are no findings on chest, abdomen, and limbs. There are no neurocutaneous markers present. Since the likely system involved is central nervous system, I would like to start my system examination. In higher mental function, patient is alert, is awake, she is awake, she is crying and speaking monosyllables and moving all four limbs. In the cranial nerves, olfactory could not be assessed. Rest all cranial nerves were examined and they were apparently intact. In the motor system, bulk was normal in all four limbs. Power appeared normal, 5 out of 5 grade in bilateral knee, shoulder, elbow joint, and it apparent as baby is moving all four limbs actively. The tone in all four limbs at knee, hip, shoulder, and elbow joint was checked with slow and fast movements. It appeared normal. In deep tender reflexes, they were readily elicitable with grading +2 in knee, elbow, ankle, and ankle bilaterally. Sir, in superficial reflexes, plantar was extensor bilaterally, abdominal and Chromatic reflex was present. Sensory system appeared normal, and there were no cerebral signs. Spine and curvature appeared normal. In the rest systemic examination, in CVS S1 S2 was heard with no added sounds. In respiratory system, bilateral breath sounds were present, no added sounds were there. And in the abdomen, it was specially examined for organomegaly. There was no organomegaly, and it was soft on palpation.
Go to the first slide of the examination. Okay. So first thing is, usually the child with epileptic spasm will not be alert, awake, and very well. They always will be very cranky, irritable, usually. So go to the next slide. Yeah. So what is the significance of flat occiput here?
Sir, flat occiput. Sir, since there is a delay, child might be lying most of the times, and plagiocephaly may be associated with.
Right. So it's a positional plagiocephaly.
Positional plagiocephaly.
Okay. Okay. So can you tell me? I am very confused here. The child has significant motor delay, and you say the tone and power of the child is normal. Can you explain how?
Sir, up to
the bulk of muscles are normal, the power is normal, you are saying the tone is normal, there is no rigidity, no spasticity, no hypotonia, there are no tonal changes. How do you explain significant motor delay in such a child?
Sir,
Yeah.
Sir, injury might not have affected the pyramidal tracts as such in very high intensity, and tracts might not be affected very much.
But the child has significant motor delay. No, if the motor system was not involved, then why the child has motor delay? I think you need to revisit the examination again. Okay, I expect this child to be having significant central hypotonia. Most of the children with neonatal hypoglycemic brain injury, initially till maybe year of age, are usually hypotonic, especially axial hypotonia. So they have very difficulty in maintaining axial tone. Okay, when they try to sit, they have a curved back. Okay. So,
sir, can it be like this? The patient till the age of 1 year, patient might not have developed significant cortical inhibition for lowering the tone, and
that is okay. You don't expect maybe spasticity at this age, but they tend to be very hypotonic. Otherwise, I can't explain significant motor delay in such children. Okay. Were there any contractures?
Sir, there were no significant contractures.
When you say the power and tone is normal. Okay, I think the examination should be done in much more detail, and I think that there is some lacuna in that examination findings versus your history. Your history and examination is not matching, so one of the things is wrong. Okay, so right, so okay, proceed further. Can you tell me the summary? And yeah.
Sir, a patient, 8-month-old female with significant delay in gross motor and mild delay in other domains with infantile spasm, with no associated dystonia or contracture.
You need to be more detailed. Okay. So localization cortex, where in the cortex are you expecting the localization? Even although the history was okay, let me ask you, how do you take the history for cortical vision impairment? One thing I told you, the recognition of mother. What are the other things that you might find in such cases? So did you check for the vision? How did you check for the vision of the child? Was the child tracking and following light?
Sir, sir, not tracking the following in light, but he was moving his head towards his mother when mother was getting out of sight. So he was tracking for her mother. She was.
Child was tracking for the mother when mother was not there.
Yes, sir. When she was there and when she moved out of sight or laterally in the left side.
No. So during examination, did you check for tracking? Was the child tracking your hand on any sudden movement, or the child was tracking a source of light?
Sir, I didn't check the tracking for source of light, but
Yeah, most of these children, maximum of these children will have cortical vision impairment. So I think you need to do that examination again. Okay, right. So the localization is where usually does neonatal hypoglycemic brain injury affect which part of the brain?
Hospital lobe and
Sorry.
posterior part, occipital lobe and cortex.
So the parieto-occipital cortex, usually the medial occipital area near the cuneus, precuneus area. Okay. So okay, I think we'll proceed. There is a lot of lacuna in the history and examination. They are not matching at all. Okay. So why did you keep a differential diagnosis of stroke here?
The patient is having so one thing, a patient had an episode of early neutral fluid that might be due to hypoglycemia, might be have an incidental finding, he might have stroke at that time, and then it's presented again since last 15 days with remote symptomatic.
A stroke involving bilateral parieto-occipital areas. No, it can't be the case. No. I think you need see your diagnosis should include the condition of the child, the possible anatomical localization, the possible pathological correlate, what led to that injury, and what is the functional status of the child. So static encephalopathy is okay, a suspected probable static encephalopathy, and it is not infantile epilepsy because it is not infantile spasms, it is epileptic spasms. The terminology has changed. I think everybody knows. So it's a child with static encephalopathy, global developmental delay, infantile onset epilepsy in the form of epileptic spasms, possible, and I think you'll find when you examine it again, possible cortical vision impairment, and most likely etiology being neonatal hypoglycemic brain injury, but inborn errors of metabolism, some of them at least, cannot be ruled out at this point of time. Okay. So how will you proceed with the management?
Sir, we will order for some few investigations.
Which investigations?
Sir, first of all, we look for complete blood count.
To look for, just tell me the investigations that you are going to do and why they are needed.
Sir, the complete blood count to sir look for sir comorbidity like anemia, because the patient as such there is no history of feeding difficulties, but the patient that might not give the complete history, and there might be anemia may be found there.
There was no pallor, there was no feeding difficulty. You said the feed intake was all right. Anthropometry was normal. Anyways, okay, CBC. Next.
So
In the order of significance, what is the most significant investigation at this point of time?
Sir, an imaging, probably MRI of brain.
MRI of the brain to look for. See, this child is presenting to you with epileptic spasms. Okay, global developmental delay with epileptic spasms. What is your first line of investigation here?
Sir, global, we will look for sir thyroid function test.
Our provisional diagnosis doesn't have hypothyroidism in the differentials. No, why are you getting a thyroid function test? You'll get a brain imaging. Okay, what will you see in the brain imaging?
Sir, we might see
So it is not going to change your management. The first thing you are going to do is an EEG for epileptic
Yes, sir.
spasm, right? So
Yes, sir.
what are the findings of epileptic spasm in an EEG?
Sir, we can find hysterectomy characteristic.
Okay, right. So hypsarrhythmia pattern will be seen, and that is very classical for your
West
epileptic
syndrome.
spasms. You got an MRI done, which
Yes.
showed bilateral parietal occipital injury. What next?
Yes.
How are you going to manage this child?
Sir, first we have to counsel the parents, sir, about the disease progression and prognosis. Then, sir, management of epileptic spasms. Then, sir, management of comorbidities.
Okay, so tell me, what are you going to tell the parents about the prognosis? What are the possible things they must look out for? What are the possible complications or sequelae of a neonatal hypoglycemic brain injury they must look out for? Parents are going to ask, हमारा बच्चा चलेगा कि नहीं चलेगा? ये जो fits हैं control होंगे कि नहीं होंगे? So tell me, what is the prognosis for such a case? How are you going to manage a case of epileptic spasm? Just in brief, no need to go into details.
Sir, prognosis, sir, we might, we will tell the patient might go and convert into one of the epileptic syndrome, or few
Child is already
patients,
having epileptic spasms.
and the patient may experience significant psychomotor delay,
Okay.
and
So you tell me the issues, what the child will have, how are you going to manage them? So child is having motor delay, what are you going to do about it?
sir, we have to prescribe for the physiotherapy.
Okay.
Sir, early stimulation with different color of toys,
Right.
and sir, apart from that, medications to control epileptic spasm.
Right. What is the first line drug?
So for infantile spasm or epileptic spasm, sir, ACTH is the first drug of choice
Okay.
now.
Right.
Sir, second line is steroids, and third line may be sir vigabatrin. Or,
Steroids and ECTH is one and the same thing.
Yes,
Hormonal therapy versus vigabatrin. Okay.
Yeah.
Okay. Other management. What are the comorbidities we are looking at?
Sir, learning difficulties, walking difficulties,
So it's a
sir,
multidisciplinary approach.
feeding difficulties, sir, and
Yeah.
might be patient be having, we might look for, sir, you were telling this vision impairment, and we should have him gone for ENT for department for hearing assessment also.
Okay.
All those.
So the child will require epilepsy control. The child will require neuro rehabilitation in the form of physiotherapy, visual rehabilitation. Okay, all these things will be needed in this child. Okay. Right. I think there is a lot of difference between the history and the examination. I think it needs to be taken again.
Yeah.
There were a lot of missing things, but I think for the first time you did very well.
Yeah. Thank you.
Any question from the house, or any suggestion from the esteemed IAP Haryana members?
हाँ सर, नमस्कार। मैं डॉक्टर बलजीत मैनी बोल रहा हूँ सर।
Yes sir, yes sir.
सर, अच्छा अटेम्प्ट किया है इसने, और अच्छा इनिशिएटिव है आईएपी हरियाणा का।
Yes sir.
तो जस्ट फ्यू कमेंट्स। वन इज दैट द बेसिक्स ऑफ pediatrics is malnutrition, and he has said that MUAC of 12.5 is normal, so that can be an irritating point to the examiner.
Yes sir. I think that is a printing mistake. 13.5 should be there.
But for his learning I am saying, and Second thing is that when you summarize a case, you summarize starting from what is the chief morbidity that you are seeing, and in history, after history, what is the likely cause and what are the associated comorbidities. So, and after the provisional summary, you give a provisional list of differential diagnosis of 2-3 things which likely can produce such a clinical picture. So that will help you in discussion of the case. And cranial nerve examination is very tricky, and some of the cranial nerves require a lot of cooperation from the patients. You can also imagine how to test the hearing and other things. So just bypassing in one line can be a tricky situation. So just be careful at that point. And as Dr. Amit said, देखने में वाकई में थोड़ा सा अजीब लग रहा है कि पावर टोन सब ठीक है लेकिन उसकी डेवलपमेंटल डिले है इतना सारा, तो थोड़ा सा उसमें पावर की जो असेसमेंट है उसमें ग्रेड 5 पावर जो है वो ग्रेडिंग ऑफ पावर में आता है कि उसका वॉलंटरी एक्टिविटी कराओ, उसको रेजिस्टेंस के अगेंस्ट मूव कराओ, तो ये सारी चीजें जो हैं ये एक्सपर्ट बिल्कुल उसमें एक्यूरेसी होनी चाहिए, तभी पता चलेगा कि हाँ ये मैच कर रहा है कि नहीं कर रहा है.
It's very difficult to label 5/5 power in an 8-month-old child.
Yeah.
You can only say that the child is moving limbs against gravity and against some resistance. Maybe you do slightly scratch the child of the opposite group of muscles on the opposite side. The child will basically flex, basically in a reflex response, and then you give a slight resistance and see if the child is moving it or not. But to say the power is 5/5 and tone is absolutely normal, it cannot be the case in this child. Okay.
Okay, can I ask the resident a question? How did you test for the 5th cranial nerve in this child?
Sir, the reflex part was checked by corneal and conjunctival reflex, sir.
Actually, we just pause here. Is it recommended to do a corneal reflex in an infant? So there are issues regarding the cranial nerve examinations. It is not that simple. So please be sure while making such a statement. And only very brief interpretation can be done at such an age. Like for example, the patient can perceive your touch, and patient can suck well or chew well on the substances. And as comorbidity, I think feeding difficulties are very, very severe in developmental delay patients and dental problems. So elaborate on these issues also, which also secondarily complicate these patients with much more other problems.
Yes, sir.
So just be careful in examination and as well as when you practice, because sometimes we miss out vitamin D deficiency and other vitamin deficiencies and dental issues. So all these are to be taken care of. Otherwise, you have done well, but in your summary, avoid abbreviations like RSC or FND. You should speak them out rather than writing the abbreviations like this.
Yes. Thank you, sir.
Right.
That's all from my side. Thank you.
Thank you, sir. Naveen sir, any comment? Manoj Rao sir.
Surinder, it was nice effort from Amit. I think this was the first case presentation, and there are some lacuna, but I will just appreciate that the case was presented just on my request that team from Agroha will present the case, and you have accepted this. That's more than enough from my side this time. but Amit has done a lot of hard work, and I think we will improve later on in later cases. This is the start from IAP Haryana, and I think we will improve day by day and week by week, and lot of new addendum will be done, and we will be doing a lot of improvement in this. Thank you so much.
Thank you, sir.
Dear Amit,
I think attendance is this time very thin. We have not able to convey the message to a lot of institutes. I think we will be calling one by one, because lot of this 40s Medanta, they are having DNB students. I think we have to add them also in our group of IAP PG teacher group, so that they can motivate also motivate their students also.
Yes, sir.
Hanji Naveen. Naveen, Naveen is muted at present, I think. Naveen, unmute yourself.
Dr. Manoj.
Yes, sir. Naveen sir, can we conclude now?
Yes. Excellent case, Amit. Actually, neurology is a difficult topic. It takes time for us to understand, since left the medical college at 18 years back now. It's been almost more than 18 years. So मुश्किल लगता है यार ये मतलब
Thank you.
रिफ्लेक्स वीक हो गया काफी.
Okay.
Maharaja Agrasen Medical College Agroha, Dr. Surinder and his team for taking the initiative, taking the lead and doing this excellent work. Special thanks to Dr. Romit for moderating the session, for our PG Dr. Amit Panchal for presenting this difficult case. Well done, Amit.
Thank you, sir.
Hope next time we will work hard on this attendance.
Yeah.
I'll personally make sure that we get more DNB students. Thank you, Surinder. Thank you so much. Thank you, IAP. Thank you,
everyone.
Thank you.
Thank you all for joining. Thank you.
Thank you, sir.
Thank you, Dr. Amit, for taking the case brilliantly. Bye.